Hi, everybody. My name is Nguyen. I practice both emergency medicine and critical care medicine. You can look at my profile for further information of where I practice. But I'm going to be talking about common infectious disease that we commonly see in the ER and how to basic management of them. This is meant to be just an overall review, very basic. For each disease process, I would recommend that you read further just to familiarize with the disease itself. So some disclosure and disclaimer. Next slide. Next slide. So the most common infection that you will see overall, not just in the ED, is viral infection. Flu and cold, influenza and coronavirus, especially currently with COVID-19 infection, are most common, especially during the fall season, the fall and the winter season. With influenza and both corona too, they're highly contagious, spread by droplets or fomite, which is on surfaces. With the flu itself, there's type A, B, and C, and bacterial co-infection has the highest mortality, especially with strep and staph co-infection. Treatment is generally supportive. You treat it with Tamiflu within 48 hours of onset. We don't generally get the flu rapid antigen swab in the ER unless the patient has comorbidity that you will put them on Tamiflu because it will be beneficial. And Tamiflu has shown to decrease symptom severity and also the time that they're with the symptoms, and it cut back by 2 to 3 days of the time that they're have the symptoms. There's no benefit to mortality at all that we have known. The previous pandemic and epidemic in the past decade has been with H1N1, which is an influenza virus, influenza type A virus actually. And the previous Russian flu, Asian flu, they're also type A influenza. Coronavirus is like your common cold. However, with the current pandemic with COVID-19, which is a coronavirus, there is a high mortality when it's severe bacterial co-infection as well. The management for this is mostly supportive. You can consider antiviral. With COVID-19, we've been doing supportive care and adjunctive medication with antiviral interleukin inhibitors, plasma. And the next virus that's also pretty common, and we usually see in pediatric, is the Rsv virus. It causes about 80% of the bronchiolitis that we see. The concern with RSV bronchiolitis is that when a patient is less than 2 years old, it can cause apnea. Particularly if they're less than 6 months old. If they're 3 months or less, you should really consider admitting them, due to apneic episode. And there has been certain death syndrome SIDS, or now we call it apparent life-threatening event in pediatric because of RSV. You do a rapid antigen test, and management, just like any other virus, is supportive. For kids, they generally get very, very congested, so nasal suction is very important. There's no evidence for bronchodilators like albuterol, which we have been using in the past. So hantavirus, not as common, but it's more prevalent in the kind of like southwest area of the U.S. And it's because of the deer mouse vector. Bacterial co-infection is also cause high mortality morbidity, and it greater than 70% or 80% is it causes what we call hantavirus pulmonary syndrome. And just like any other viruses, especially the flu and the corona, it transmitted to the respiratory tract, and so it caused significant pulmonary issue. And eventually it caused end organ failure with ARDS and DIC. And management, of course, is still supportive. West Nile has been more and more prevalent in the northeast area of the U.S., and it's usually during the summertime in an area where there's, a body of water, and because the vector is mosquito, and it causes meningitis, encephalitis, and transverse myelitis. To diagnose this is clinical suspicion along with lumbar puncture and send it to serology. Mortality is about 18%. The management is supportive as well. And the bigger management is mosquito prevention and control. Next slide. You see herpes infection pretty common, and one of the more common one is, not so much of chicken pox, but shingles. And usually you see this in, adult or older, elderly patient, where they have the characteristic, unilateral dermatdermal distribution of a rash that's painful and burning. Usually the shingle, it's a reactivation of the herpes zoster virus. And the way you treat this is that you put them on antiviral, plus or minus steroids, and of course, pain medication, particularly nerve medication like gabapentin and Lyrica. If you started within 24 hours with the antiviral, you can decrease the severity and also the length of time that they're with the rash. But some patients do develop like a long-term, sensory issue where the rash, has been with time, and some even permanent. Hepatic ophthalmologis is a infection by the herpes zoster for the digemital nerve, and characteristically you see dendritic lesion with fluorescein stain when you see it under a microscope or with the blue light. And sometimes, not very often, it's actually a rare sign. It's what we call the Hutchinson sign, where there's a rash at the tip, that painful rash at the tip of the nose. They definitely, these patients definitely need an ophthalmology consult within 48 hours because of the, the eye involvement. And you treat them with antiviral, ophthalmic, you can treat them with PO antiviral and ophthalmic steroids. But, in order to, if you're going to start them on steroids, you should really discuss it with ophthalmology, because long-term use of ophthalmic steroid can cause high pressure in the eye, and so opto needs to check their pressure in the eye like within 2 days, and that's why we recommended follow up with them within 2 days. The herpes infection can go into the ear as well, and it causes what we call the Ramsay-Hunt syndrome. So generally, you will see any, some sort of rash on the face, or even facial nerve paralysis, and then you see a rash or ear pain. It doesn't have to be a rash, but if they have like a lot of ear pain, then you got to suspect it. I mean, the treatment still is antiviral and steroid for 7 days. The next infection that you see kind of common is, especially, in a immunocompromised patient, HIV transplant, is, the Cmv virus. In HIV, it causes, rhinitis and colitis in transplant patient. You treat them with antiviral based on which organ is being affected. Next slide. HIV and AIDS, we don't really see a lot of them, but we do see patients just because they go to the infectious disease clinic. But it's good to know a little bit about it. Usually when we see an HIV AIDS patient, we ask them, when was their last Cd4 count, because that's important. And when, in terms of which organ is potentially with an infection, and when they have an ID follow-up, and what kind of antiretroviral viral therapy that they're on, and if they're compliant. So HIV and AIDS, HIV is the virus and AIDS is the syndrome. It's multi-organ. For neural, it can cause, encephalopathy, dementia, the HIV and dementia. The cryptococcus depend on, what the Cd4 count is. Toxoplasmosis, and generally when you get a CAT scan with IV, you will see the ring enhancing lesion. And then the neural lymphoma, which also ring enhanced as well. Each of these have their own, modality of treatment in terms of antibiotic and antifungal. So, the most important thing is to kind of diagnose them with lumbar puncture and imaging. Pulmonary, your community-acquired pneumonia is, the most common. But don't forget about PCP or PJP, the pneumocystic pneumonia that generally we see in immunocompromised patient, not just in AIDS. And that is the #1 AIDS associated mortality. And the way that you diagnose it is you, of course, you do a lumbar puncture. And if their LDH on the CSF analysis is increased, and they have a PaO2 of less than 70%, you got to start them on steroid because that will decrease mortality. Mycobacterium Avm Pneumonia is also common in these patients, but less than, I would say, 10%. And of course, since they're immunocompromised, don't forget about fungal infection as well. GI, most common will be your thrush and esophagitis. They can be caused by fungal or virus. And then, of course, they have the colitis, diarrhea. Skin, any bacterial, viral infection, but characteristic with HIV and AIDS is the Kaposi sarcoma, which is actually not a virus, but like a tumor. The other thing that we worry about in these patients is the Cmv Meningitis, which is the most common cause of blindness in HIV, so we can't miss that. Next slide will show you Cd4 count and what to worry about in terms of Cd4 level. But, don't worry about these levels. These levels should give you a clinical suspicion, but, based on your diagnosis on your exam and history as well, and whether they're complying on their medication and follow-up. Next slide. STD is very common in the ER. I would say every shift that I work in the ER, there's 1 or 2 cases, and also it depends on, the location of the practice. But the most common, it's the most common STD is chlamydia and gonorrhea. It has a high rate of co-infection together. So when we treat one, we always treat the other. And that's why we have the cocktail of macrolide with a cephalosporin or doxycycline. It can cause, in women, it can cause a pelvic inflammatory disease and even infertility. And in both, men and women, it can cause septic arthritis, especially with gonorrhea. So it's something that we should treat and not wait while we're waiting for the swabs the swab or the urine study to come back. If you look at the illustration on the right, chlamydia, and this is, I think, data from 2 or 3 years ago, which I don't think has changed much. In the past 2 years, chlamydia have almost more than 1.5 million cases, and gonorrhea is about, almost 500,000. You don't see syphilis a lot, and you don't see definitely herpes a lot. But, when you talk to the patient and you have high clinical suspicion, even if they're not symptomatic, especially if they're exposed to their partner who has it, you definitely gotta treat it. And then, recommendation would be no intercourse for 7 days. Repeat, their culture or swab in 1 week to make sure they clear the bacteria. And you should always treat the partners as well. Next slide. So syphilis, trichomonas is more common. So I would say the three top would be chlamydia, gonorrhea, and trichomonas. Syphilis is not so much, but it is also prevalent as well, and it's caused by the Treponema pallidum bacteria. It causes 4 stages, and the reason we categorize these stages is because of symptoms and also how we should treat them. Generally, with the first stage, you will see a rash and a painless ulcer. In the later stages, especially the latent or the tertiary, the last stage, if remain untreated, it can cause problem like aortic aneurysm and neurosyphilis with dementia. And so it's important that we diagnose and treat this. The way you diagnose this is serum, or even lumbar puncture with the CSF, VDRL, and then serum RPR. And then if they have lesion, general lesion, or even rash, you can scrape them and put it under microscope. The way you treat this is if it's the first stage, you can give them penicillin, but after that, it's a prolonged course of 2 to 4 weeks. You can do penicillin, a third generation cephalosporin, or even doxy, and then you got to treat their partners as well. Just know that, it doesn't really pertain to us in the ER, but when they're on the floor, it can cause a reaction, what we call the Hersheimer reaction, where they have constitutional symptoms, fever, body aches, and all that. And this is secondary to the lysis of the infected cells, and usually they're self-limiting. Herpes simplex, it's also another STD that causes painful. Syphilis causes painless genital ulcer. Syphilis will cause painful vesicle, and you treat this with safe sex practice and also antiviral. Trichomonas will cause PID and vaginitis, and the way you diagnose is a wet mount, and you can actually see the trichomonal protozoa with the, I actually saw it once on a wet mount. You can see the flagella as well. But you treat this with mostly with flagyl, and you also treat the sexual partner as well. Next slide. So in terms of wound infection, tetanus, we don't really see the actual disease itself anymore because of vaccination. But tetanus is caused by a Clostridium bacteria, tetany, just like the Clostridium bacteria that's caused C. difficile diarrhea. And Clostridium is, it's a spore that lives for a while in soil and, on surfaces. And what it does, the tetany Clostridium will inhibit the release of GABA in the brain. And this caused almost like a spastic, in terms of the muscle and peripherally. Most classic, that's the reason why it's called tetanus, is prolonged spasm and lockjaw syndrome. And the most common sign, I actually saw one patient with trismus, and it was an unvaccinated patient who family doesn't believe in vaccination, and he came in, his only presenting sign is trismus. And then the other thing too is that any stimulation will cause them to go into spasm. And they have this kind of hypersympathetic vital sign too. And the most common cause of death will be respiratory failure due to spasm of the respiratory muscle. Diagnosis clinical, and it's also lab work with culture. But the way you treat this is, the tetanus antibody around the wound to neutralize the toxin and the vaccine. And if it's bad enough, do some wound debridement and put them on antibiotic, covering the anaerobes, which is Clostridium with flagell or Clinda. You would probably try to avoid a penicillin because it can potentiate the toxin effects, but this have not been 100% proven. Magnesium, if they go into prolonged spasm and autonomic dysfunction with the hypersympathetic drive. Benzo, of course, for the spasm. For these patients, it's better to put them in a quiet, dark room with not a lot of external stimulation. And of course, supportive management as well. So Mrsa infection for wound is very common. We usually before characterize it by community or hospital. Excuse me, hold on. Hello. Yes. Hi. Yeah. Yes. Mm-hmm. How's his blood pressure? Yeah.
5, 4, 3, 2.
What? Hello?
Yes, I'm sorry, it's recording now.
Oh, okay. So for Mrsa, we used to separate it to community acquired and hospital acquired. We still using right now, but it's not as regimented as before. We still treat patients with, Bacterium Pneumonia for cases that are not severe, even if they're inpatient. And then, for severe cases, even though like it's considered community, we still treat them with Vanco and Zyvox. So Mrsa is pretty prevalent now in the community, and what we worry about, it's, just like necrotizing infection with strep and staph. With Mrsa, it can cause this syndrome, what we call the Valentino Leucocetin toxin syndrome, where it causes severe cytotoxin and cause necrotizing hemorrhages, particularly in the lung. And when they do have this, there is a, almost like 80 to 90% mortality, and it could cause next FASH too. And there's study, involved in terms of doing, anti-inflammatory medication to try to help with this. But once they have it, the mortality is very high. Next slide. Botulism is also pretty common. We worry about infant, especially with honey because of their immune system. And it can cause like symmetrical descending flaccid paralysis and some bulbar muscle. And generally, the bulbar muscle symptoms like the eyelid problem and facial problem generally occur within 48 hours. For adults, most often it's a wound issue. But, with bioterrorism, there's a concern for inhalation as well. And what botulism does is it's also a Clostridium bacteria. It blocks the release of acetylcholine. And people die from respiratory failure. The way you treat this is you give them anti-toxin to bind to the circulating toxin. For infant, we don't usually do this just because of side effects. And the treatment is also mainly supportive with airway and wound management. Next is also very, very common. Actually, one of the more common for wound infection is rabies. Overall, 80% has been associated with bats, but in the community, about majority of the cases are dog bites, particularly with domestic owned dogs. Other animals has been associated with rabies or skunks, raccoons, fox. Generally with all these animals, if you get bitten, if you can trap them and observe them for 10 days to see if there's any, if they're symptomatic. That's why it's always, essential that if you've been by an animal or a dog, you tell your local Department of Health, and they will try to go out and, capture the animal and put them in observation. But the transmission is through saliva, through the bite. The clinical symptom is pretty rare, but, because of, we generally treat it if there's high index of suspicion for rabies. However, if you do develop the symptoms, it's generally pretty fatal. And most of these clinical diagnosis postmortem. But if you become symptomatic, you get delirium. It's all like, neuropsychiatric issue, like bizarre behavior, autonomic dysfunction, and a fear of water. The way we manage this is if there's some sort of like suspicion, we put them on a vaccine. It's a series of 4, but if it's, high index of suspicion, it's 5 days, 5, doses. And also, you should also start them on antibodies as well around the bite site, and also, wound care and antibiotics. If you're not sure whether you should start the vaccine series or the antibodies, you should really call your local Department of Health, and they generally have a 24 hours line that will help you with that, make that decision. But, if you're thinking about it and you're not sure, you should just do it anyway, give them the vaccination. Next slide. Necrotizing fasciitis. We have seen this a lot in the past, but we have managed it a little bit better. So it's, the mortality has been less. They're not calling neck fascia anymore. They're calling it, soft tissue infection, necrotizing soft tissue infection. And it starts out as a cellulitis and progresses to a myositis, which is infection, a fasciitis, which is infection of the fascia, and go down to the muscle, which is myositis. And once it spreads to the fascia, it's generally very rapid, within 48 hours. And when it goes spread through the fascia and down to the muscle, there's high mortality if we do not debride the tissue, the dead tissue. There is 3 types, but the most common is probably microbial, meaning there's multiple bacteria. However, if there's one bacteria, group B strep will be the most common. On exam, paying out of proportion and hemorrhagic boli would give you, you should really, really worry, and especially if they have signs of compartment syndrome. The way you diagnose this is kind of like clinical judgment and suspicion, but you can also get x-ray to see if there's gas, which is kind of pathognomonic for this, disease. You can get a CT scan, but oftentimes, if you have high suspicion, you just start them on antibiotic, call surgery, and get them to the OR to debride the tissue. If you're not sure and they're kind of borderline, you can use the laboratory risk indicator for next FASH score, which is the score on the right, bottom right. And it's a score based on inflammatory markers and creatinine, all that. And if, higher score, you should have higher suspicion. For me and a lot of us, if there's a suspicion, we start them on an antibiotic and call surgery or admit them. The most diagnostic, other than surgery, is an MRI. A CT is not that well defined. Even if a CT is negative, it doesn't mean that, they don't have myositis or fasciitis. An MRI or even a bone scan would be more diagnostic. But the most diagnostic would be in the OR, take a look at the tissue itself. So management for this is, really early recognition based on your clinical suspicion and surgical debridement, along with antibiotics. Your antibiotic choice should cover gram-negative, gram-positive, and also anaerobes. The most common I would, like I say, is Group B strep, but there's also staph and Clostridium as well. Next slide. Next slide. Tick-borne illness. The most common you'll see is Lyme, and sometimes Rocky Mountain spotted fever. So Lyme is caused by the Borrelia parasite, and it's from a tick deer. Deer on a tick. It has 3 stages. The one that you probably wouldn't see the most is the characteristic rash of erythema migrans, which is the target rash. About 80% would develop this rash, and usually after 24 hours. If you don't treat this, they can go into problem later on in terms of heart block and cranial nerves palsy. And when they develop heart block, cranial palsy, or even meningitis, you should really admit them for prolonged antibiotic, IV antibiotic, generally 3rd generation cephalosporin. The way you diagnose this is PCR and serology. If the tick attachment of the bite is less than 24 hours, you don't really have to do anything. There's minimal risk. Or if there is a tick that's visible within 72 hours, you can give them a prophylactic dose of doxy, 200 milligram, 1 dose, and they'll be safe and protected. But if you do diagnose it and the serology ELISA does come back positive, they should be on doxy or penicillin or cephalosporin for 2 to 4 weeks. And you gotta admit them if they have meningitis, signs of meningitis, heart block, and arthritis, so that they can get IV antibiotics. So Rocky Mountain spotted fever, the presenting sign would be rash around the wrist, ankle, and the thumb. And they will have petechial rash too on the legs. And particularly when you put pressure on it, there will be petechia. It can cause, misdiagnosis of this can cause vasculitis, myocarditis, and, sometimes meningitis and encephalitis. And it's caused by the Rickettsia bacteria, and it's also from a tick. And the way you treat this is doxycycline as well for 1 week. Next slide. Some of these tick-borne illnesses that you're not going to see on this slide. However, you can look through them. However, the one that I will talk about is tick paralysis, because it's pretty common in kids. And of course, it's by tick. And so any kids that come in with a rash and they have neural issue, particularly motor issue, you should worry about tick paralysis. And it's secondary to inhibition of the acetylcholine release in the brain. And generally, they become symptomatic after 2 days of tick bite. And characteristic would be an ascending flaccid paralysis with intact sensory. So it's mostly all motor. The way you treat this, of course, with any tick-borne is remove the tick and supportive management, plus or minus antibiotics. So on the right lower, kind of tells you how to remove a tick. So you want to, kind of get a forceps and remove the tick at the head where the bite is. Because if you, use the forceps at the body, you will remove the body, but not the actual tick where the bite is. So, remove it at the head and put it in a bag, and you kind of like looked at it to see what kind of tick it is and to see what, whether it's Lyme or Rocky Mountain spotted. And then you treat the local bite with, antiseptic, and topical antibiotics, and maybe even like an antihistamine to help with the swelling. Next slide. So pneumonia is pretty common. You'll see this pretty often. People who have this are people who have heart and lung disease that are at risk, and immunocompromised patient. And what I'm going to talk about is bacterial pneumonia. So bacterial pneumonia is more common in adults. In kids, it's more, viral pneumonia is more common. So in terms of bacterial pneumonia, we classify it as community acquired versus hospital acquired. The most common community acquired is still strep pneumo, and post-influenza pneumonia is your strep and staph, co-bacterial infection. Typical, it's a lobar, meaning a particular lobe of the lung, and which, you will have all these like particular characteristic to particular infection, but they're not always. A lot of times they overlap. For instance, even though strep pneumo causes rusty color, other, bacteria can cause that too. The current jelly, this is more of a test taking, for tests. Klebsiella is, the current jelly and causing the bulging fissure. And staph, of course, you worry about the Valentino Leucocetin toxin, especially if they have like hemorrhagic cavitary lung lesion. Atypical pneumonia will cause kind of your interstitial opacity. And usually when you see this, mycoplasma will be your number one. And other things that mycoplasma can cause is a rash and bullous meningitis, meaning that they have a rash in their ears, like a bolus in their ear. Legionella can sometimes cause lab work-wise GI symptoms like abdominal pain, nausea, vomiting, diarrhea, and it all can cause decrease in sodium level. So the way you diagnose this is, of course, getting a sputum culture and gram stain and a chest X-ray, or plus or minus a CT chest. When you have an abnormal X-ray that shows consolidation on a chest, you don't really have to progress to a CT. You only get a CT if you're not sure. Community acquired, if they're, moderate symptoms and you feel like they don't have a lot of comorbidity and they can be managed outpatient, azithromycin or doxy for your atypical coverage, and the penicillin. Levaquin, a quinolone will have both a atypical and typical coverage. And Levaquin, because of the high rate of resistance, I like to use these days moxifloxacin, which is very good lung penetration and has not shown to be causing resistance. You can also do like I say, a penicillin, which is also will cover your most common bacteria. For inpatient, you do IV, third generation cephalosporin along with coverage for atypical. You can also use levaquin, levofloxacin or moxifloxacin for both typical and atypical coverage. For severe community-acquired pneumonia that require ICU level of care, or if they're intubated, we generally add Mrsa coverage with Vancomycin. And if it's during the season too, even if they were swabbing them for flu, if they're sick enough, we generally put them on like a 5 days course of Tamiflu for viral coverage as well. And if they're sick enough, we do chest PT and encourage mobility if they can to, and pretty much lung physical therapy. And of course, bronchodilators, steroids, and mucolytic. Next slide. Hospital-acquired pneumonia. If they're in the hospital for more than 5 days, or if they're at a chronic health facility, bacteria suspicion would be both your typical and atypical. Most common would still be your strep pneumo. You also worry about, especially with people who have chronic diseases in chronic healthcare facility, is Pseudomonas and Mrsa. Diagnostic tool will be still the same for community acquired. Your antibiotic management will be a little different because of Pseudomonas and Mrsa coverage. But also you should include a atypical coverage as well with azithromycin or doxycycline, and strongly consider antiviral with Tamiflu. And like 2 or 3 years ago, there was a new guideline from the Society of Infectious Disease that say, you know, even if they're coming from a healthcare facility or in the hospital, if it's not hospital acquired and they look well enough, you know, you can just cover them with typical and atypical coverage and not have to worry about Pseudomonas and Mrsa. So they really leave it up to you how sick the patient is and what your suspicion is. There's no strict criteria like before where, oh, they're from a chronic health facility and nursing home, you know, then we definitely, you know, got to cover them for Mrsa and Pseudomonas. The only thing that hasn't changed is that if a patient is chronically vented, like if they have a trach, then yeah, you absolutely have to cover them for Pseudomonas and Mrsa. Or if they have a previous history of Pseudomonas or Mrsa pneumonia, then you should really cover them until you get their culture, sputum culture, and de-escalate the antibiotics. So aspiration pneumonia is pretty common, especially in your elderly and your alcoholic. And immediately, you know, there's a chemical pneumonitis, but, you know, eventually there will be a polymicrobial infection. And it's usually anaerobic from the GI tract. But, you know, so generally with aspiration pneumonia, you kind of look at the patient. If they're doing fine and their x-ray doesn't really show much, you know, the recommendation is that you hold antibiotic and you actually do aggressive lung physical therapy, because if you can help them, because initially it's the pneumonitis, the inflammation. If you can help them through that, they will not develop into a bacterial infection. However, if they're elderly and they cannot participate in lung PT and they start developing high fever and they have worsening respiratory status, then yeah, you should cover them with antibiotic, particularly with anaerobic coverage. However, we do cover them for typical, atypical too, until, like I say, we get the culture to come back and then de-escalate. If they're chronic aspirator, you know, if you don't fix this, they can actually progress into pulmonary fibrosis. And one of the most common cause of pulmonary fibrosis in the US is from chronic aspiration at night. So diagnostic tool is kind of the same. Management, like I say, is supportive, aggressive, lung therapy, and consider anaerobic coverage. So fungal pneumonia, you don't see that often, but you know, you worry about people who are immunocompromised. Next slide. And fungal pneumonia, you see that in with spores in the soil. And when you see these, you know, pneumonia, particularly when they're not getting better with antibiotics, you know, you think about fungal, especially if they're, you know, in some sort of immunocompromised state. One of the characteristics of fungal pneumonia is hemoptysis and cavitary lesion. The way you diagnose is, of course, with sputum culture and NDS stain, and you actually look at the underneath the microscope. You treat this with antifungal. Some of these, you know, kind of like suspicion with the histoplasmosis, coccidioid mycosis, plasmacosis, and the most common that you will see everywhere, kind of insidious, is Aspergillus. So for histo, you know, it also depends on where the distribution is, where it's more common. You see it most common in the Mississippi, Ohio River, you know, Valley. Cocci, you see it in the Southwest, and Plasto, you see it in the Midwest and Southeast. Aspergillus, like I say, it's pretty insidious, and you see it everywhere. What you see on CAT scan is a fungus ball, and oftentimes patient will have hemoptysis. And you definitely need to be aggressively treating this because people will die from it. Next slide. Endocarditis. It's a pretty bad infection of the endocardium with valve involvement. The most common would be your strep and staph, which is the skin, strep viridin and staph aureus. Other bacteria that you'll see too is Enterococcus, and then the less not so common is fungal. So in your IV drug user, so it really depends on kind of their symptom and their history. If they're IV drug user, you worry about the right-sided, disease, valve disease with the tricuspid. And with the native valve, you worry about the left side of the heart. Most common will be your mitral valve and aortic valve. Risk factor, like I say, is drug user, prosthetic valve, people who have prosthetic valve, rheumatoid, rheumatic fever. Signs and symptoms is actually kind of depends on, even though there's overlap, whether it's right-sided valve involvement or left-sided. So for your right side, you can have, septic pulmonary emboli. And generally you see a patient with a history of IV drug use, and they come in with, like septic emboli on their x-ray, like, little opacity. And the other thing you worry about too is, possible involvement of the extremity, because right-sided you see legs edema, and maybe like also congestion of the liver. But oftentimes they're short of breath, they have chest pain, they have a murmur. Left side disease, oftentimes will show neural symptom because embolism to the brain, and also the spine. So if they come with like, back pain, you have to rule out spine lesion. These Janeway lesion, which are like, septic emboli to the extremities, characteristically you see like petechial rash on their fingers, some and so, and they can have like conjunctival involvement with hemorrhage. And then you can have mesenteric ischemia as well. But like I say, these symptoms do overlap. Like if you have a drug user with back pain and shortness of breath, you have to really worry about, listen to the heart. If there's any, murmur, then it's, most likely endocarditis. If you don't hear any murmur, endocarditis should still be your, high clinical suspicion. The Duke criteria, it's what we use for suspicion of endocarditis and severity. But definitely in all these patients get get blood culture and echocardiogram plus or minus imaging of their spine. If you do a transthoracic echo and you don't see it, would recommend doing a transesophageal echo to see the extent of the valve involvement and to see if there's any valve involvement if the suspicion is high. You treat this with, of course, pulmonary support with oxygen. With the native valves, you do a penicillin along with gentamicin. It's pretty effective. For your IV drug use, you worry about Mrsa, you still start them on Vanco. For your prosthetic valves that become infected, we recommend that you cover for Mrsa, and gentamicin and rifampin as well. Fungal is very rare, so I wouldn't worry about it too much. And if it gets bad enough where there's a lot of involvement or the vegetation is greater than, I believe, 5 centimeters, then they need valvular replacement. So on the right of the slide, next slide, you can see the Duke criteria. But like I say, you don't really need these criteria to to diagnose it. Diagnose your clinical suspicion should be the diagnosis. Next slide. Pericarditis is inflammation and infection of the pericardium. Most often it's idiopathic, but secondary would be your viral infection. It can be bacterial, parasitic, TB, or aseptic in terms of autoimmune disease, but that's not very common at all. And medication induced as well. Usually these patients with pericarditis, they do get the pleuritic chest pain that worsen with breathing and then improve with leaning forward, but not always. They, of course, get short of breath, secondary to pleural effusion. Pleural effusion is another common finding. And sometimes you will hear that friction rub on auscultation. What we worry about pericarditis is that it can cause, heart issue in terms of the myocardium. It's not so much of myocarditis with infection and inflammation of the myocardium, but you'll see like characteristically on EKG, you can diagnose it on EKG, but you can diagnose this even if the EKG is unremarkable. But on the EKG, generally you will see this diffuse ST elevation and PR depression. And then the other thing that people tend to miss on EKG is PR elevation in the AVR lead, and without any reciprocal changes that we would see with MI. Lab work wise, you'll get SED rates and troponins. Sometimes troponin will be elevated, but often not. The SED rate will be elevated. You definitely need to get an echo on all these patients, to rule out valvular issues, to rule out myocardial issue, and then also to rule out pleural effusion, not pleural effusion, pericardial effusion, which is the main concern for pericardial tamponade. And the way you treat this is with an anti-inflammatory. NSAID and colchicine has been shown to be effective, plus or minus steroids. And if they have pericardial tamponade or effusion, you drain it, of course. Next slide. Just give you a little information about pericarditis and how you treat it and image it. Next slide is inflammation of the myocardium or myocarditis. Most often, almost always, is viral. Sometimes you can get bacterial, and often associated with pericarditis as well. So often with myocarditis, you get pericarditis, but with pericarditis, you often do not get myocarditis. So usually, with the phases with myocarditis, it can be acute, subacute, or chronic, secondary to chronic fibrosis or chronic inflammation. These patients will develop shortness of breath, intermittent chest pain, palpitation, and signs of arrhythmia in terms of syncope, dizziness, and palpitation. Of course, you always have to get an EKG and an echo on these patients. EKG will show, arrhythmia, heart blocks. Echo will show wall abnormality, dilated, cardiomyopathy, and also, pericardial effusion. Lab work wise, definitely get a troponin because most often it will be elevated and it can be very high and just SED rate. If the treatment for it is supportive, you can put them on steroid to help with the inflammation. You can put them on a ACE inhibitor to help with the remodeling with the cardiomyopathy, or if it's bad enough, you can put them on IVIG antibody for the virus. I've seen patients who are sick, very sick, and require ECMO because they go into cardiogenic shock. Next slide, kind of give you a chart flow of the process and kind of how you would treat it for myocarditis. Next slide. So meningitis. Meningitis is inflammation of the meninges covering the brain, the spinal cord. Often it's bacterial, but you can get virals as well. Before, strep pneumo, Neisseria and Listeria are kind of common. Not so much H influenza, but now because of the vaccination issue with the people who don't believe in vaccination, H influenza has been, on the rise again. Viral, the most common I would say, is herpes, and fungal is crypto. Generally, they have meningeal sign with headache, neck stiffness, pain, fever, photophobia. Sometimes they will have seizure, And, meningeal sign in terms of like when they flex their head or extend and flex their knee, they will have like neck pain. And, the way you diagnose this is, of course, get a, lumbar puncture. They generally recommend you getting a CT scan before you do a lumbar puncture to make sure that there's nothing else going on and make sure there's no edema. Because if they have signs of, edema in their brain, doing a lumbar puncture might herniate them, but that's rarely happened. And I would always recommend starting antibiotic with clinical suspicion right away instead of waiting for your LP and your CAT scan, because that will decrease their mortality. And once you get the lumbar puncture, send the CSF for analysis. But for these patients, always start them on Vanco to cover for Mrsa, Rocephin, and plus or minus ampicillin for your atypical coverage. For people who are above 50, you should definitely cover for the atypical coverage like Listeria, with ampicillin. So, generally the recommendation, if they're above 50 in age, you start them on ampicillin along with Vanco and Rocephin. Vanco and Rocephin has a very good, blood-brain barrier penetration, so that's why we use them. And steroids, will also decrease mortality and neural sequela in pediatric. And especially when the culture come back as strep pneumo, Neisseria, or H influenza, the steroid will definitely be very, very helpful. Of course, if it's, concern for viral, you start them on acyclovir for herpes and antifungal, of course. Next slide. Encephalitis is inflammation and infection of the brain parenchyma, the brain tissue itself. And it's often a progression of the meningi, but sometimes with these viral infections, you can get, gross encephalitis without the meningitis. Most common will be your viral infection, herpes, and Epstein-Barr, and recently the West Nile virus. Bacterial and protozoa-wise, you can get it with Lyme and toxo as well, but usually that's with your immunocompromised patient or patient with untreated Lyme. So, how can you differentiate between, in terms of symptoms, between meningitis and encephalitis? So with meningitis, they generally come in very high fever, but they're not, often neurologically intact. And with encephalitis, they generally don't have a lot of fever, but there's some neural abnormality in terms of like change in mental status, neural deficit, or seizure, or they have behavioral changes. And that's the other thing I forgot to mention for meningitis. With viral meningitis, especially with herpes, they will have behavioral changes, and that's also another suspicion for hepatic meningitis. And often these, patient with the encephalitis, the meningeal sign can be there, but it's definitely obvious in meningitis. So the way you diagnose this, again, is with a lumbar puncture. Sometimes you have the brain because you're not sure whether their neural deficit is from like inflammatory infection versus ischemic stroke. And worst come to worst, if you still don't know, brain biopsy to confirm the diagnosis. Initially, you treat this with empiric antibiotic, but once your CHF culture come back negative, then you de-escalate your antibiotic, and continue acyclovir. And treatment for this is generally supportive, and a lot of these patients will end up with long-term neural sequela. Okay, next slide. Brain abscess. So brain abscess is an actual abscess within the parenchyma, or within or outside the dura. Often they're polymicrobial. The progression is generally pretty insidious. They will have meningeal sign, and oftentimes they will have neural deficit. And the neural deficit is actually what, kind of pinpoint your clinical suspicion. You definitely need a CT with contrast to see the ring enhancing lesion. So if you have a patient with neural deficit and you worry about brain abscess versus encephalitis, definitely get a CAT scan, but I would recommend a CT with and without, because if you see a enhancing lesion, then it's definitely an abscess. Then you don't have to go through the lumbar puncture. Antibiotics for this will, be the same thing as meningitis, but you incorporate flagell to cover for anaerobes. And oftentimes these will require surgical drainage. Next slide. So we'll talk about some pediatric viral infection, which, kind of more what we're going to see in adults now these days because of the vaccine issue. So measles is generally a pediatric disease, but, we're seeing scattered cases of older kids and, rarely in adults, but, I feel like in the future we'll start seeing, in adults as well. So it's the Measle virus, which is a para-mix virus, and it affects the epithelial of the trachea and the bronchus, and it goes into the limbs. Transmission is, of course, respiratory. Incubation's, period when you start developing symptoms is medium. It's about 8 to 9 days. These patients generally have high fever. They cough. The 3C, is cough, coryza, and conjunctivitis. And often in kids, you will see these couplet spots, which is kind of like white spot at the posterior oropharynx. And they will have a rash, macular petechial rash from the face downward. And if it's bad enough, they can develop, the viral pneumonia along with bacterial co-infection. And the other thing, which is not so common, is the panencephalitis, which can persist, up to which can, manifest itself like even 7 to 10 years post-infection. You diagnose it with serology, and pretty much you treat it supportively and antibiotic if there's bacterial infection. You should really isolate the patient from pregnant women and elderly because of questionable or the higher rate of miscarriage and premature birth in pregnant women. And of course, the measles is preventable with the vaccine in early childhood. Next slide, scabies. We see this kind of often in our ER, depending on demographic of where you are, location-wise, your practice. But it's caused by mites, and symptomatic is generally due to close contact with someone who has scabies. And it causes a type 4 hypersensitivity reaction, which is T-cell mediated reaction. And that causes like intense histamine release and the characteristic rash that is, papular and erythematous with the burrows due to the scabies. And generally you find at the webs of the fingers or, toes. You can also see them in the axilla and the groin as well. You diagnose it by kind of like symptom clinical, and you treat this with permethrin, ivermectin, and avoid sexual contact and wash everything in hot water. That's pretty much it. The most common thing that you'll see, you'll see other stuff too, but they're not so often. So I hope this is helpful. If anybody have questions, please let me know. Thank you.